Welcome to This Week in Infectious Disease. This week we're covering 6 notable papers spanning major clinical themes, including the optimization of treatment for opportunistic infections in vulnerable pediatric and adult populations, the evolving landscape of antimicrobial resistance and diagnostic speed, and the public health trade-offs of expanding preventative therapies. Let's dive in. We begin with a focus on managing opportunistic and severe infections in highly vulnerable patient populations. In a major publication from the Lancet, researchers reported the results of the Empirical trial, a multicentre, open-label, group sequential, factorial, randomised, controlled, superiority trial conducted across 19 hospitals in Côte d'Ivoire, Malawi, Mozambique, Uganda, Zambia, and Zimbabwe. This trial evaluated whether empirical valganciclovir treatment for cytomegalovirus improves survival in infants living with HIV who are hospitalised with severe pneumonia. The study enrolled 563 infants, aged 28 to 365 days, randomizing them to receive either standard of care, which included standard treatments for bacterial and pneumocystis, girovacine pneumonia, or standard of care plus 15 days of oral valganciclovir, or standard of care plus empirical tuberculosis treatment, or both interventions combined. Analyzing the valganciclovir comparison groups, the researchers found that valganciclovir did not show a statistically significant reduction in all-cause mortality when evaluated via traditional intention-to-treat analysis at the primary endpoints. Specifically, at day 15, 23% of infants in the valganciclovir group died compared to 27% in the groups without valganciclovir. By 12 months, mortality rates were 43% and 48% respectively. However, when the investigators applied a time-varying effects model, they observed a significant early survival benefit, with valganciclovir associated with a 40% reduction in the adjusted hazard of death at day 15. This survival benefit remained notable over 1 year when excluding early deaths that occurred within the first 48 hours of treatment initiation. Reassuringly, severe adverse events were not more common in the valganciclovir arm, suggesting that empirical valganciclovir represents a safe and potentially life-saving early intervention for high-risk infants in these settings. In a parallel effort to understand opportunistic infection mortality in adults, a cohort study published in Open Forum Infectious Diseases examined the characteristics of mortality in 743 HIV-negative patients with cryptococcosis. While cryptococcosis is classically associated with advanced HIV cases among HIV-negative individuals are rising. In this cohort, the overall mortality rates were relatively low, but highly concentrated in the early phases of care, with a 2-week mortality of 1.4%, rising to 8.4% at 10 weeks, and 12.2% at 1 year. Multivariable analyses revealed that advanced age, higher baseline modified Rankin scale scores, altered mental status, elevated total bilirubin levels, increased peripheral white blood cell counts, reduced serum albumin levels, and elevated creatinine levels were independent risk factors for death. To understand geographic variations, the authors conducted a meta-analysis of 4 large-scale cohorts, comparing Chinese and Western populations. They found that solid organ transplantation and active malignancy significantly increased the risk of early mortality, with a relative risk of 1.5. Meta-regression indicated that the higher early mortality seen in Western cohorts was largely driven by older patient age and a higher prevalence of these severe underlying immunocompromising conditions, highlighting the need for highly tailored clinical risk stratification based on regional patient demographics. Next, we shift our focus to antimicrobial stewardship, treatment optimization, and the surveillance of drug-resistant pathogens. Writing in the International Journal of Antimicrobial Agents, investigators shared findings from a non-inferiority randomized controlled trial and meta-analysis comparing tegoprazan amoxicillin dual therapy against an optimized bismuth-containing quadruple therapy for first-line Helicobacter pylori eradication. The trial, conducted in China, randomized 258 treatment-naive patients to either 14 days of the dual therapy or a quadruple regimen consisting of esomeprazole, amoxicillin, tetracycline, and bismuth. The results showed that tegoprazan amoxicillin dual therapy failed to demonstrate non-inferiority to the quadruple regimen. Eradication rates in the intention-to-treat analysis were 83% for the dual therapy versus nearly 91% for the quadruple therapy. In the per-protocol analysis, the rates were 89% versus nearly 96% respectively. While both regimens showed similar safety and patient compliance, a subsequent meta-analysis of 7 randomized trials confirmed that tegoprazan-amoxicillin dual therapy resulted in a significantly lower eradication rate than bismuth-containing quadruple therapies containing amoxicillin and tetracycline or metronidazole. These findings suggest that despite the simplicity of dual therapy, optimized quadruple therapy should remain the preferred first-line standard of care. In the same journal, a global surveillance report from the 2024 Antimicrobial Testing Leadership and Surveillance, or ATLAS program, evaluated the activity of cefiderocol against more than 1,600 carbapenem-resistant Enterobacterales isolates. Cefiderocol is a critical siderophore cephalosporin designed to treat highly resistant gram-negative infections. Globally, overall susceptibility to cefiderocol remained high, at 93% using Clinical and Laboratory Standards Institute criteria, though it fell to 81% under the stricter European Committee on Antimicrobial Susceptibility testing criteria. Crucially, non-susceptibility rates varied dramatically by genus and species. While Klebsiella species demonstrated excellent susceptibility with a non-susceptibility rate of only 3.5%, Escherichia species showed a high non-susceptibility rate of over 25%. Species-specific analysis revealed that Enterobacter kobe had a non-susceptibility rate of 50%, compared to just 7% for Enterobacter hormaicae, while Providencia redgeri exceeded Providencia stuarti. Although unadjusted data suggested that isolates from Asia had the highest rates of resistance, a multivariable logistic regression adjusting for clinical factors revealed that the specific bacterial genus was the dominant independent predictor of resistance, while the geographic effect of Asia was attenuated to a non-significant trend. Alarmingly, genetic profiling of the non-susceptible isolates revealed that nearly 44% did not harbor any identifiable carbapenemase genes, pointing to alternative mechanisms of resistance that clinicians must keep in mind when managing these highly resistant infections. Our final theme explores how diagnostic advancements and public health delivery models impact infectious disease outcomes and healthcare systems. A systematic review and meta-analysis on behalf of the Hellenic Microbiological Society and the Hellenic Society of Chemotherapy evaluated the diagnostic accuracy and clinical utility of rapid molecular testing for severe infections and sepsis. Analyzing 49 microbiological and 33 clinical studies, the meta-analysis found that rapid molecular tests performed on positive blood cultures achieved an exceptional pooled sensitivity of 97 to 98% and a specificity of 99 to 100% for gram-negative bacteria, gram-positive bacteria, and yeasts. Clinically, the implementation of these rapid tests shortened the time to pathogen identification by more than 21 hours and reduced the time to optimal or adjusted antimicrobial therapy by nearly 14 hours. Although there was no significant difference in 30-day mortality, the rapid diagnostic pathways significantly lowered total hospitalization costs, confirming that early, actionable molecular diagnostics are a vital component of cost-effective, high-quality sepsis care. Meanwhile, in the realm of prevention, a modeling study published in the Journal of Infectious Diseases evaluated the potential population-level benefits and clinical risks of low-barrier, over-the-counter access to daily oral pre-exposure prophylaxis, or PrEP, using tenofovir disoproxil fumarate and emtricitabine. Using a stochastic network-based model of gay, bisexual, and other men who have sex with men in Atlanta, Georgia, the researchers simulated a 10-year period under varying levels of expanded PrEP access. They estimated that a 50% increase in PrEP coverage through low-barrier over-the-counter access would avert over 15% of new HIV infections. However, the model also highlighted significant clinical risks associated with reduced clinical monitoring. Patient exposure to renal impairment rose from 2.5% to nearly 5%. Hepatitis B virus reactivations reached over 2 cases per 100 person-years, and drug resistance events among those who did acquire HIV rose more than 12-fold, from 0.68 to 8.4 events per 100 incident infections. Importantly, sensitivity analyses demonstrated that requiring a confirmed HIV-negative status at initiation could reduce drug resistance by more than 90% without reducing the overall prevention benefits, while periodic renal monitoring could successfully mitigate the risks of renal toxicity. This study underscores that while low-barrier distribution can greatly expand HIV prevention, preserving basic clinical safety functions is critical to maximizing its net public health benefit. If you only have time for one paper this week, make it the Empirical trial. This multicentre randomised controlled trial provides critical, high-quality evidence on the potential survival benefits of empirical valganciclovir for cytomegalovirus in infants hospitalized with severe HIV-associated pneumonia, showing a significant early survival advantage in time-varying analysis without a signal of increased harm. Here are the key takeaways from this week in infectious disease. First, empirical valganciclovir for cytomegalovirus in infants with severe HIV-associated pneumonia may offer a significant early survival benefit within the first 2 weeks of treatment, with no evidence of increased severe adverse events. Second, when treating Helicobacter pylori, do not substitute optimized bismuth-containing quadruple therapy with tegoprazan-amoxicillin dual therapy, as the dual regimen failed to establish non-inferiority and demonstrated low eradication rates in meta-analyses. Third, cefiderocol remains highly active against most carbapenem-resistant Enterobacterales globally, but clinicians must remain vigilant regarding genus and species-specific resistance, particularly in Escherichia and certain Enterobacter species. Fourth, rapid molecular diagnostics for positive blood cultures significantly accelerate pathogen identification by over 21 hours and time to optimal therapy by nearly 14 hours, reducing overall hospital costs, even though 30-day mortality remained unchanged. And finally, while low barrier or over-the-counter access to HIV PrEP can significantly reduce community transmission, clinical implementation must preserve safety measures, most notably HIV testing at initiation to prevent drug resistance and basic renal monitoring to avoid toxicity. That's your roundup for this week in infectious disease. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.